Well, it's straight up on the hour, so we're going to go ahead and get started. Welcome to our second conversation about the COVID-19 sharing current practices to support PFCC in times of rapid change. Really appreciate all of you joining us. I'm Mary Minetti with the Institute for Patient and Family Centered Care, and I'll be moderating today's discussion kind of live. And my co-worker and colleague, Marie Abraham, will be monitoring the chat so that we can keep track of what's going on in the chat and make sure that we bring to your attention any great ideas or resources or links that others on the call create. You'll notice that there is a quick poll for you to fill out, and we'd like you to take just a minute to do that. It's always great for us to see who's in the room in terms of roles, and I know people are chatting in names and where you're from. We've got some Canadian colleagues as well as people throughout the United States, and that's great. So we will give you just a couple minutes to fill out that poll as people are joining. And we have made this our second conversation about COVID-19 based on your feedback that it was helpful to get together with colleagues and share what's currently happening. And knowing that things are changing rapidly, you requested that every couple weeks we got together and just checked in with each other to see what's new and what challenges people are facing, and also what great ideas they've had. We also have our technical support person, Natasha Reed, behind the scenes, making sure that everybody can get in or handle any kinds of issues that may come up for you with your technology. I know that she put together a really nice FAQ that went out with the slides this morning. Kind of talked a little bit about how to make Zoom work best for you. So I found that really helpful for me, a great reminder, so we can do that. Natasha, I'm wondering if you want to go ahead and close the poll. I don't know how many people have responded, hopefully a number of people. Okay, great. So it looks like we've got about a third of the participants are patient and family advisors. Thank you so much for joining us. You are important partners with us during this time of rapidly changing information and ways to keep people safe and also respect their important role in healthcare. And we've got almost half being coordinators who are working with patient and family advisors, but also serving as liaisons to the healthcare organization.
You don't like it?
And there are a number, there's physicians and nurses and some measurement and quality people. As a quality person, I always love it when there's quality people that can join us. And so, and community programs are really important partners with us in healthcare, regardless of our setting. So we've got a nice mix of individuals who have joined us today. So if we can go ahead and close the poll and move forward to kind of set the stage for this conversation. That's those of you that are on the phone may not be able to see these slides, but I hope that you were able to download them when they were sent out by Natasha before this meeting. So this is an important conversation and we want to move right onto it. Let me just have Natasha go to the next slide. I want to just remind you that although we do webinars and we do have a couple recordings on COVID-19 and best practice strategies on our website at www.ipfcc.org, we also use this chat time as really an opportunity for us to share with each other what's going on. We always leave all of the resources and recordings available to anyone, and they're on PFCC Connect in the conversation poster or in the conversation folder. And we look forward to those of you that have resources and ideas to share them real time with us during the chat, links or documents or those kinds of things. And you can certainly do that after the fact as well. So let's really quickly do one more poll, Natasha, and that's really for us to see where people are from in terms of what kinds of settings? Are you primary care? Are you a community organization, a hospital or medical center? We have a number of continuing care communities becoming very interested in participating, and we hope that there are some of those continuing care communities as well. So take just a minute to do that, and we'll kind of see what the lay of the land is that may affect, you know, what direction the conversation takes. And in scanning the chat, I don't see that anyone is from Minnesota, but I do know a good friend of mine just had 4 inches of snow in Minnesota. I'm sitting here in 32-degree weather with sun and blue sky, but I hope wherever you are, you're safe and well. I know that there have been some high winds in certain areas of the country, so it's quite a range of weather as well as situations across the world. So Natasha, if we want to go ahead and close that poll and see where we're at. Okay, so the majority are for hospital and medical centers. We're going to try to cover a little bit about long-term care communities. That was a question that came up from a number of you in the registration point. But we will try to make sure that we meet everyone's needs on these calls. And so let's get started. We can go to the next couple slides. I think one more, yeah. So one of the things, despite how difficult this is for everyone, patients and families and healthcare providers and community heroes, I am struck by how much hope is created by the behaviors and the choices that people are making to protect their neighbors and others in the community. And so I hope that you find that the conversation today is a hopeful conversation and one where we are able to come up with some really great ideas about how to respond in positive and proactive ways in what is a difficult time with COVID. If we can go to the next slide, I wanted to share a message from one of our colleagues, Terry Griffin, who's a nurse practitioner in an NICU, and she shared this with colleagues over the weekend and gave me permission to share this with you about the challenges that we're really facing. And she said, this is a scary time. Our NICU continues to welcome both parents while some have banned anyone from coming to the NICU. We've stood firm. I applaud our director for standing firm. I can also share it's been hard to maintain physical distance. I gave a sobbing mom good news. She fell into my arms sobbing. The dad jumped off the chair and gave me a big hug. What can you do? We are human first, I guess. And that really is an important message for us to remember, that we're all human and we're in this together. And by sharing what we're doing and what we're learning, we can support each other in the journey that we're on. So I want to talk a little bit about the conversation that we're going to have today. If we can go to the next slide, Natasha, that'd be great. So these are some of the things that people wanted to learn from each other. And so I'm just going to kind of go down the list and see if there's somebody who wants to share what they're doing about any of these things. And if you have something to share and you can take yourself off mute and want to share that real time with us, that's great, so that we can hear that. If you need to share it by the chat, we encourage that as well. Sometimes people are working in, although not so much anymore with COVID-19, but you may still be working in an area of your home where there are other people, and so you aren't able to take yourself off mute, and so feel free to use the chat for that. So is there anyone that can share something about how they're conducting virtual rounding on patients?
I can.
Great.
I'm Marielle from Lucille Packard Children's Hospital.
Great.
We, for the past, I guess, 4 weeks have been calling all inpatient families between 5 parent mentors and our Latino Family Resource Program coordinator. So we divide those up, and usually now we have the same families on, we've divided the floors up so that we each have the same cohort each week. And so we work together to figure out what kinds of topics we're going to cover in addition to providing support. So initially, those were changes in policy around visitation, things like that. We always emphasize, of course, hand hygiene, social distancing, and things like that. Now we're moving on to making sure they understand what resources are available to them. And then now, as we get further on, it's a lot more support as they feel fairly isolated in the hospital.
Great, Mariel. Thank you for sharing that. You mentioned that you have some of your patient family advisors as well as your Latino resources working with you on making these outreach calls. Is there anything specific that you did to prepare your PFAs to feel comfortable making these outreach calls?
The 4 people that are doing it, we are all parent mentors as well. So we have had a lot of training in this thing, but it's usually we see people in person. So we've had to do it and some additional training and brainstorming as far as how that's going to work on the phone.
Great, great. It's wonderful that that role can continue to happen, even though we have to make it happen in a different kind of way.
Yeah.
So thanks for sharing that. Is there anyone else that wants to share what they're doing in terms of virtually rounding on patients?
This is Steve Bocat. I just want to, we're not doing literally that I'm aware of virtual rounding. As a PFA, we're basically not allowed in the hospital at all. I'm in the state of Maryland. We've had in the Washington metropolitan area a fairly heavy outbreak. Our governor has prohibited anyone from going in the hospital other than patients. We have a very small pediatric practice. They are allowed to have one parent with them. But what we have done is posted on our website how to use various communication tools so that families can communicate with the patients and with the staff. So, and anyone can go to our suburban hospital. If you Google Suburban Hospital, Bethesda, Maryland, under the COVID-19, there's about 5 or 6 listings of using FaceTime, Zoom, Google, whatever they call it, and complete with graphics and so on. So someone's not familiar with using it on their phone or their iPad or whatever. And anyone could, duplicate those if they want to use it within their own systems as a guide to families. We have a very elderly patient population. The families tend to be older. Some of them may not be familiar with using these tools, but it is something to try and facilitate discussions with patients, between patients, families, and staff.
Great, great. So maybe Marie can find that out, that link out there while we're continuing the conversation and put it into the chat so that we can see the materials that you've developed. Thanks so much for sharing those. So one of the questions that came up had to do with long-term care patients and supporting residents and clients and families during this time. And I know we have a couple people on the line. We've got Leah and we've got Lillian who, actually Leah, sorry, from the Peak Senior Living and Health and Rehabilitation. Leah, did you want to talk a little bit about what life is like in your setting and what kinds of things that you're doing?
Hi, absolutely. When it first started, we were on lockdown early, and it really was hard for the residents. But now that time has gone further, I think it's even harder for them. So we had to start getting more creative. We did exactly what Stefan said, the FaceTime and the Skype and all that initially. But now that we've been into this for over a month in Arizona, that we're finding that that's not enough, because in our community, we've canceled all our group activities. And that interaction, even with each other, is super important. So we started getting creative on trying to bring back some of those activities without compromising, the CDC guidelines. So we're still doing bingo, but it's hallway bingo. Happy hour is really important in our facility for our independent living. And so we did driveway happy hour. So we started figuring out how to get that social interaction without compromising the safety of our residents. Family members have been really good because, as you know, they can't come into our facility, they've been putting little notes and quotes and things like that on the residents' windows. So when they wake up, they might see that. Or we have communication more face-to-face through a window, so they can actually physically see them. I think one of the things that we've also done is we're finding that since there is no group activity, they're spending more times in their rooms, in their apartments, and that's just not healthy. And so now we've assigned very specific staff to specific residents where we could, you know, take them for walks or do their nails or have that more meaningful conversation that goes above just saying, how are you doing? Well, we know they're not doing well. So we're trying to do more meaningful interactions with them so they don't feel so isolated. And I think because this has been going on so long, it's easy to forget that that isolation piece is very real and it's not getting better.
Mm-hmm. It sounds like you have been very creative. Can you describe to me, I can understand hallway bingo. I can put a picture of what hallway bingo looks like, but talk to me a little bit about the driveway happy hour. How does that work?
So we have, in our community, we have bungalows, which are like patio homes or small houses, wherever, depending on side of the country you live on. So the residents that live there are independent living. So they come to the end of their driveway and we had happy hour being passed around to them so they could talk from their distance. So it's their houses are probably, 10 to 12 feet apart, but at least they can see each other. Because you have to think about the independent livings are very, they hang out together all the time. They have their own clubhouse and they have their own activities and now they're all afraid to come outside their door for very legit reasons. And so we wanted them to remind them that, you still have your neighbors. So this doesn't happen at the Peaks, but I did hear a really cool idea that I think someone should adopt. But they had a cul-de-sac where someone played music and everybody came out to their driveway and they had their own cheese and happy hour on their driveways and they got to listen to music. I think that's a really good idea, because that's very healing, but it's still not breaking any of the boundaries. So I wanted to share that because I'm going to probably steal that one at some point. But
Great. Thank you so much for sharing. Is there anyone else from a long-term care community or a residential facility that wants to share what they're doing? Leah, you've certainly shared a lot of great ideas and even ideas that could be used in neighborhoods that aren't long-term care communities. Did I hear somebody else's voice? Okay. So as there are outbreaks in certain areas and situations and decision-making needs to be changed, I'm wondering how different organizations are addressing those situations and decision-making and how they might be involving patient and family advisors or whether they have an incident management system or how people are addressing outbreaks. Is there anyone on the line that has had a recent outbreak situation and can talk about what their process is? That may not be something that is currently happening for people. So we're just going to move on.
Actually, Mary.
Oh, yes. Hi, Paula.
I don't know if it directly addresses the question, but we are trying to move medical personnel to different hotspots. We're a volunteer pilots organization. We typically fly in small planes where distancing is not possible. We're not an air ambulance, so we don't have a real mechanism of disinfecting these. It's just like putting somebody in your private car. So we're looking at ways to honor our mission and be helpful. And because most of us are not medical personnel, we do have some board members or past board members that are and have some experience that have been helping us navigate this. But we're finding that with daily changes to the information, it's like standing on shifting sand that we're having a very difficult time. These are very painful decisions for us because we want to honor our mission. We're leaving patients high and dry. We still feel that they're exposed to a lot less by flying in a small plane than flying on a commercial airline or getting on a bus or something else. So we're trying to pivot, fly supplies in the meantime while we've shut down our patient flights, look to help caregivers get to these hot spots. And we have some help from Alaska Airlines now that is donating some flights for caregivers. We're flying some people from Anchorage to New York and from Anchorage to here where I am in Arizona on the Navajo Reservation, where we've had a particularly bad outbreak.
Mhm.
I don't know if that's really helpful to the conversation, but that's kind of what we're struggling with right now.
Yeah. Well, it is helpful to the conversation, Paula, because it reminds us that there are organizations like yours that are out there that care, that are part of the healthcare fabric. You may not be a hospital system, but you certainly interact with patient and families and hospital and other kinds of systems. And I think that what's true is that ability to pivot and think about how can we provide the best service at this time and still contribute to helping. And your supply example is a great one. But it is hard. It's hard to kind of reframe who we are in this moment. Not that we aren't going to be able to, it's not always going to be like this. And certainly we're going to take the learning that we've had and have, a better future. But it is tough, and I appreciate you sharing that. I'm noticing on the chat that we've got some other individuals. Margie Dayton, if you want to talk, if you can get off speaker and share what Trinity Health Michigan is doing in terms of how they're addressing their decision making, that would be great.
She's
Hey, Mary Minetti.
Yes,
Kelly,
hi.
Kelly
Can you hear me?
Manuel.
Can you hear me
Well,
now?
Oh,
I
go
can.
ahead.
I can.
Okay. Yep. This is Margie. So hi, everybody. And for Trinity Health Michigan, for each of our hospitals and ambulatory groups, we have a formal incident command center set up. And as we anticipated huge surge in numbers, we, of course, were wrapping up with a 5-phased incident command surge model that supported surge to the highest level. Things are leveling off in Michigan a little more quickly, especially in West Michigan, thank goodness. And we will keep our incident command structure going as long as we see value. So our main focus, as with any incident command need, is to support the frontline providers and colleagues, and to ensure that we have PPE and that questions are answered. And so it's a very deep and broad structure. We have a colleague hotline as well where they can call with questions and for emotional support. The calls are triaged and supports are put in place immediately for colleagues or providers that have anything from a question to a potential exposure. So lots of formal structure set up. In terms of decision making, it all gets handled through that formal incident command structure where the commander is the highest level, and then we've got 5 different chiefs that take on the different functions.
Are there ad hoc opportunities for seasoned patient and family advisors to be part of those conversations?
We not within the formal structure, and we have actually talked about that with previous incident command needs. However, this time it came on so fast and furiously that we didn't attempt to make that connection. We're instead using our patient and family advisory councils or individual patient family advisors in more of an ad hoc. So we have a meeting tonight actually with one of our patient family advisory councils where our presidents are meeting with them and talking through the challenges, the plans, the surge plan, where we are now, what we anticipate, and then inviting their feedback about things that we might be missing or that we could deepen in any way.
Great. That's a great example of when things are rapidly changing. Sometimes we don't necessarily get patient and family advisors involved in the actual structure, but that we create space and opportunity for them to provide input. And then as we think about moving forward, when we're not in crisis, thinking about, you know, where was the value and how might we think differently about how we organize those particular structures so that it's a real-time kind of thing. But thank you for sharing that, Margie.
Mary,
Yes.
before you move on, I would like to ask a question of our colleague in Michigan. This is Ioana Popescu from the Canadian Patient Safety Institute. I wonder if this incident command system and process is integrated somehow with the patient safety reporting and learning system, or something similar in Michigan.
That's a great question. We have actually, for all of Trinity Health, we have a new chief safety officer, and he was a little behind because he had just started, but he's also, I'm meeting with him in a couple of hours to talk through how we are making better connections, how we can make better connections there. But I can't say we have done that effectively in the, you know, rapid pace of initiating search planning and such. So I'd like to learn more, and I plan to do that on this call with him this afternoon. So it's a great point. I wish I had more to offer.
Great. Well, Margie, yes.
I just wanted to see if anyone had any ideas out there. For us, our biggest challenge is taking patients from the hospital that do not obviously have COVID, but our screening process is so stringent. You know, it's very difficult to speed up that process. So I think for us is the hospitals are trying to keep their census, you know, low so they can bring in COVID patients, and they're relying on rehabs to absorb those patients. Or would we take a positive that went negative COVID? And I think those are huge conversations out in the community about how we can support the hospital without jeopardizing safety. So one of our struggles.
Yeah, I imagine. How have there been others that have had to deal with that particular issue that Leah just mentioned that have some insights or suggestions? We're going to go ahead and move on, but let's watch the chat, Leah, because they may be able to chat in. And the other thing is that when you guys raise issues that someone is not on the line to have you know, be able to share what they're doing, we keep a tally of those kinds of things that we haven't gotten great ideas from. And so as we're reaching out to others between these calls, we keep these things in mind so that we can integrate them into FAQ kinds of documents, which we're working on. So if we,
Hey, Mary.
yes.
It's Kelly Goodson with Vizient.
Hey,
I just
Kelly.
wanted to let you know, hello.
Yes.
I posted in the chat resources that Vizient has in 6 different areas. And it's, you know, open to the public. So if you're interested, especially Leah, surge capacity, you know, if you want to check out that section, you might see something in there. I haven't read each section completely. I'm on the clinical practices team and the visitation team, so I know those documents well, but you might want to check out the surge capacity area to see if there's any information there for you.
Great. Thank you, Kelly. Thank you for bringing that to our attention.
And I just reposted it, so it's down. It should be in everybody's chat. So in case you missed it, in the chat goes fast.
Yeah, the chat does go fast, but you do have the scroll bar so you can scroll up and down to pay attention. And the other good thing is we do print out the chat and we post that and send that out to you so that it's kept as a document with information on it. So this has been a great conversation. So I'm going to kind of move on. I want to thank Katie Mayer for also sharing information about COVID-19 that you've got on the Stanford Children's Health website. I love when people begin to look at how they can help us see what else is going on. An issue, and there are a couple questions about this, has to do with, you know, how our organizations, hospitals in particular, I would think, and most of you are from hospitals, communicating to families when they can't be present and there are patients on respirators, or when, another question on this, and they're related, so I'm going to surface both of them to see if there's some interest in this conversation, but how organizations are doing end-of-life conversations with family that can't be physically present if there haven't been, you know, orders or advanced directives and those kinds of things. obviously the proactive thing, and it's happening in primary care, is a number of virtual conversations are happening around advanced care planning for people who have serious chronic conditions, and with some anticipation of, we're going to try to keep you safe, and here are the ways to do that. And have you thought about what your wishes are if something were to happen? But anyone have some insights or some processes that you want to share about those kinds of situations that are happening?
Mary, this is Caroline DeLongshaw.
Yeah,
I don't know that we're doing anything unique at the Medical University of South Carolina that's not being done other places in the way of using iPads and cell phones to stay in touch with families. But I think one of the things that we have been trying to be vigilant about is, sometimes we create processes or we create things where we're working with development to raise money and get donations of new iPads. We've created tip sheets for our patients and how to use iPads, both to keep patients and families connected, but also to utilize during rounds and important conversations. And so we can say that we're doing those things, but have we really operationalized them? And so my friend Kelly Lloyd is on the line, on the call as well. And what keeps us up at night is worrying about how have we really operationalized the use of those iPads? And when we hit our surge and things get really busy, has it become a part of who we are to offer the technology twice a day? I mean, I know we're doing it for important conversations. I know we're doing it end of life situations. But what is really important for the majority of our patients who are separated from their families, are we asking and encouraging the use of that technology for these really important partnerships that are important now more than ever, 2 times a day, 3 times a day, whatever it may be? So the first thing is making sure that we have the technology available. And so we're working with our telehealth friends and IS to make sure that it is available and that it can be used for those reasons. But I think the more important thing, and Kelly helps us keep our eye on the ball with this, is that we're operationalizing it, that it is going to become a part of who we are. And I think we have buy-in from our chief quality officer. When I have a conversation with her, that's like, this is not just about how we operate in this crisis, because I have a feeling we're going to be working this way. This will be our culture beyond the COVID crisis, right? The use of this technology and the way we offer it to our family members who don't have a parent or a family member at the bedside might be how we work for a very long time. I think it's sort of going to change the way we provide healthcare and partner with our families for the long haul, not just during this crisis.
Yeah, I think, how do we bake it into the way that we do it, and enlarge what the options are, not necessarily diminish them long term, because we will eventually be able to welcome safely families and loved ones into the care environment. But even when we welcome them, there are going to be people who don't have close individuals who can come and physically be with them. And so the more we can develop competency in that is really important. Karen, Anthony asked you, I think, Carolyn, as you're thinking about that process, whose job is it to offer those asking those questions? Is it the volunteer services, or is it nursing, or is it social work, or have you developed any kind of standardization or have had conversations around that?
Yeah, that's a great question. I mean, we're working on that right now. So, and we have to be very flexible because things are changing by the day. So at my health system, we furloughed 900 of our care team members on last Monday. And it's a really scary time. It's a scary time for our patients and families, but it's a really scary time for our MUSC family, because we're having to adapt to new ways of working. So our volunteer department is temporarily closed. And it was scary for my department because it changes the way we onboard, or the way we do not onboard, new patient and family advisors at this current state. So the folks that we have now have always been precious, but they're even more precious. And it's really important that we keep our connections with them to make sure they're involved in this really meaningful work. So keeping them a part of that conversation and involving them in some of these decisions that are being made. So we have a meeting after this call about the use of the iPad technology and how do we operationalize that. I invited one of our nursing directors to our adult PFAC meeting that took place last night. She was a new member to the council. And I extended that invitation just this week, just knowing she was gonna have to say no because everyone is so overwhelmed with work right now. But she accepted, and I was beyond grateful because many of our advisors shared stories about interactions and experiences that they've had in the last few weeks. One of them had a recent ED admission, and she talked about how the doctors and nurses, she was a little bit out of it. She had a shunt malfunction, and she was talking about how she was kind of in and out, but the docs and nurses were telling her that they were in contact with her mother and her husband. And to her, that meant that her mother and her husband were getting updates. But in reality, what she learned later is that they weren't getting updates because she hadn't shared the code with them. And so because I had that nursing director on the call, thank goodness in real time, we were able to pivot and make some changes so that she could reach out to her nurses today to say, we got to figure this out like right now. We need to make sure that when people are on arrival, our patients are being given the code and told to give it immediately to someone in their family so that they can be continually updated. So that was heartwarming for me because it was watching our PFAC in action make some really necessary changes about things that keep me up at night.
Great. Thanks for sharing. There's a lot of really amazing stuff going on in the chat about videos that are being made to celebrate staff. And Sue Collier's doing some logging and journaling what they're learning during the time so that they can take that information and move it forward. So if you haven't had a chance to take a look at the chat, I encourage you to do that. It's always amazing to me how quickly the time goes. Rather than go through every one of these questions, because I also want to kind of put a spotlight on PFAs and what we're doing there, are there any other comments or thoughts that people want to have about any of these learnings that you see up in front of you in terms of next things that you're doing or lessons learned that have become really important things that you want to share?
Hi, this is Kate Mayer from Stanford Children's Hospital, and what
Hi,
we've
Kate.
done for our department, because everybody can't come in, is we're going to send out a weekly newsletter just to keep the parents informed of what's happening in our department. We're starting to do virtual family advisory councils, and we're thinking about doing a town hall for the parent advisors or some kind of summit. We haven't quite evolved that yet, but we're trying to stay in touch so people stay connected. And then we're starting to try and do e-councils where we can send out a survey to parents and get a quick answer to some questions that staff might have.
That's great. Wonderful example. Thanks. So I'm going to ask Angie, or not Angie, sorry, Natasha. I think we have another poll that's kind of a lead in to the next conversation that we're going to have, just so we can kind of see what people are doing. So we've given you a list, and you'll notice there's a scroll bar on this poll so that you look at the entire list, and you can check as many of these things that apply. But it lists some of the different ways that that we've heard that PFAC members are engaged throughout different organizations. And we're just curious, with this group of 68 people that we've got on the line, what are some of the practices that you are doing? So if you can just take a minute to check any of those that apply, we'll kind of see where, you know, what the general practice is out there. I mean, I think that's part of what we're trying to do, is by staying up to date with you and the sharing that's happening, is to just see what's happening out in the field and get some kinds of ideas about things that maybe some are doing, but not all are doing. So I can't see how the poll's going, but Natasha, I'm gonna ask you to close it when you think you've got a fair number of people that have responded so that we can kind of see what are the practices that are out there.
I'm going to give it just a few more seconds, Mary.
Okay,
The
great.
results are coming in, but they're coming in a little slowly.
Okay, thank you for letting us know. I noticed that there are a couple really great questions that are in the chat that after we see where people are at, we may want to explore, but one is from Susan that says, what wisdom or thoughts do PFAs, and we've got quite a few PFAs on the line, would you have to share with crisis leaders to consider? What would you have wanted them, what are they doing that's helping you, and what are things that they could do that they aren't doing that could be useful to you in your role? So
hi, Mary.
Hi
it's
there.
Brenda, calling
Hi,
you
Brenda.
from small rural Saskatchewan. We have, and I'm a patient family partner, and I've been with the health authority for the past 10 years. So I participate on a number of different committees and different experiences around quality and safety and those types of endeavors. I would like to say that I would imagine there is not a patient family partner, patient family advisor anywhere globally who doesn't want to get involved and is ready, willing, and able to help. We also understand that this is a time of survival. It's a time of life and death. And so we get a little bit impatient, if you will, that some of us have not been asked. And it's very inconsistent from what I can gather across Canada. I've been for the last month, we've had bi-weekly meetings virtually with pan-Canadian different groups who are patient family advisors. Some are in research, some in quality and safety, some are in direct care, and any and all aspects of what we do. And I have found that that has been very helpful to have that connection and the experiences of what is going on across Canada. Because fortunately, for rural, smaller provinces, we have not had the deaths, if you will, that life and death experience that's happened. We've only had 4 deaths in all of Saskatchewan, and we've only got 1 million people here. So it's been a struggle for us as patient family partners to get involved. But being one of those patient family partners that doesn't take no for an answer sometimes, I have found ways to have input, and I've been staying in touch with our patient client experience portfolio on a weekly or as a needed basis. Our executive director has sent out communications that they have asked for our input in around advanced care directives, around the visitor policy, around end of life policy, also messaging how do we continue with those of us who do not have COVID-19, but we have ongoing chronic conditions and we need to come to either primary care or the emergency or outpatients or wherever at times to get our treatment. And so I would say that we just want to help. And this is the message I want to leave with you today, because we have to think sometimes about end of life care. And I would say to you, in my role as a patient family partner, I care enough to live my passion every day. I'm going to stop there.
Thank you, Brenda. I so appreciate your comments, and your passion definitely comes through in your tone and in your excitement and in your dedication, and I know many of you are. I'm noticing on the poll that that probably the most thing that is happening with PFAs is that the coordinators are available to connect with individuals to keep them informed. So that's a way that people can reach out to those individuals. and that your monthly meetings with your PFAC are using virtual methods to meet on that monthly basis. And although it's a small number, I appreciate that 12% of you answered that your PFAC members serve on the incident management team, helping shape some of the policies and the procedures. Is there anyone on the call that wants to talk, a PFAC member who wants to talk a little bit about what the experience of being on the incident management team is?
So, hi, this is Kelly Lloyd. I work with Caroline DeLongshot at the Medical University of South Carolina. And I will say that I was one of the ones that responded of being able to help shape policies and procedures. And primarily that's due to working with Caroline and her reaching out to get my input. But it's also based on the relationships that I have created through the years in my work as a patient family advisor, not just on the PFAC, but just in other ways as an advisor. And by creating those relationships with the care team members, it puts me in a position where they will reach out to me directly to get input on different family communication that they're writing or on different policies that they're creating. So I think what it reinforces is that PFAs can't just be brought in to help out in times of crisis. They have to be embedded and engaged with care team members on a regular basis, so that in times like this with extreme need, then it will be front of mind to want to partner with them in creating and advising on things that relate to patients and families. So I think that's where the greatest benefit to me and why I've been included at this high level is because of those partnerships and relationships that were created prior to the start of this outbreak and pandemic.
Mm-hmm. Great, thanks for sharing. You know, I think it really is around the relationship. And I think about if you're on the call and you're a PFA and you haven't heard from your hospital system because of the crisis, even reaching out to ask the question, how can I help? As opposed to do this for me. It's really a interest in maintaining that relationship and communicating to the healthcare partners that you've built relationship with over time is that you want to help and you may not know how to help. And so asking the question, how can I help? There may be some ideas that they can share with you that would be helpful to them. And so that becomes really important.
Mary, if I could just very briefly, one of the ways, because we've talked a lot about the things PFAs can do, and I think the email that went out from Bev and the Institute for Patient and Family Centered Care weeks ago sort of felt like, I don't know, maybe years ago now, was really helpful as someone who does this work, because I was able to copy and paste and of course give credit for a lot of it, but to send it out to our PFACs and our leaders, just about, it was like 3 bullets of things that we can still do together. And that was my reminder to our councils that there are still things that we can do together, even though we can't be together. But I know that our leaders are concerned. Our CEO mentioned something on one of the leader calls about, you know, the first week it was fine that we were spending the majority of our time working on all things related to COVID. But at some point we have to get back to our new normal with COVID as the baseline. And I think it's my job to make sure that we don't forget who we are. It's everybody's job, but my job in particular, because I do work with our councils and our patients and families. And I think one of the ways we don't forget who we are is to make sure on these leadership calls, and we've only just begun, we created a thank you video, but I think that can only be the tipping, not even close to the tipping point, there's more that we can do. But to make sure that these thousands of leader calls that take place a day, there's a DCI call, there's a leader call at noon, there's a HIAC call at 3 o'clock. All of these calls should start with a patient story. And by story, it could be 30 seconds long. But just an example of what it feels like to be a patient today. And it could be kudos to the care team. It could be a story about what somebody has experienced. But I think that's part of not forgetting who we are as a healthcare organization and not letting patient and family centered care become a thing of the past.
Yes, and I think all of you are on the call because you're very committed to having that be be the future, that those partnerships, we don't want those to be past partnerships. We want those to be current partnerships in whatever way makes sense now and helps keep people safe and respectful of needs in the moment, but also that long-term commitment. So it's very well said, Carolyn. I'm noticing that there's all kinds of stuff on the chat, and I know that you've been monitoring that fairly closely, Marie. Is there anything you want to bring attention to that's been in the chat?
Well, there's a few things, and I thank you, because this has been great to watch all the sharing of ideas. Going back, just want to loop back to the end of life and advanced care planning topic, because we have had Deb Sprague from Spectrum and Sue Collier and David Brackett chatting in with some I think important reminders to connect with community organizations and other organizations. So at Spectrum, I see from Deborah, and I don't know if you want to speak about it, but you're partnering with the Ronald McDonald House in your area to help with the end of life. I don't know, Deb, if you can get on.
Sorry, I was having a hard time unmuting myself. Sorry about that. Hi, everybody. Yes, so really it's been an opportunity for us to partner with Ronald McDonald for any of those end-of-life situations. We've had, I think, a handful of those, not just COVID-related, but also just end-of-life related, to be able to use our Renucci House, which is our hospitality house, which is connected to the hospital, allowed us to be able to, in a much more comfortable setting, really loosen up our visitor guidelines here in Michigan. You're able to have one for end of life, nobody in the ICU. So it allowed us to be able to have family members to be at the bedside for end of life situations. So that's been a nice piece. And then I also did add too, serving as a resource for our community and our businesses. For those, we're still on lockdown, no essential services are there, but for those employees that are still having to go to work, we put together kind of a helpful tip for our employees, for businesses here in the community, of how to make sure that their employees are still healthy too. So some of the quizzes and checkers that we're all doing, that we're providing to them too.
Oh, great. And it looks like you provided some links to this. To that resource, so that's great. That's great.
You know, the other another theme that's been coming up is you know, the coordinators, the PFAC and the PFA coordinators are really trying very hard to keep their advisors connected, as well as providing input. But I do see that a number of people are working with smaller groups of advisors. So the people that can commit to being available on a very quick basis to do some rapid response to requests that come in from staff. So it's another, you know, you can use all your advisors, but you might want to build that smaller group or cadre of advisors.
It really is the day of or the word of the day, which is we have to be nimble and flexible. And we have to be gentle with each other. We're doing the best that we can. And so some of you may be on the line thinking, oh, well, we haven't done that. You know, you hear an idea and rather than be upset with yourselves that you haven't done it, you just need to be gentle that you've done the best that you can and under the circumstances, and then gently ask yourself, how might we be able to take some ideas, not every idea, but some ideas, whether it's a quick patient story or it's getting input on a particular messaging document. And how can we make that happen in a way that's not so burdensome as to kind of tip the cart over? Because we have to be aware that it's a stressful time for everyone, and we may not all be working at the highest levels of our productivity, and that's normal. That's what people are saying is normal, and so we need to not judge ourselves by the old standards, but be kind and gentle to ourselves in the interim. Kelly, I appreciate you sharing some information, and David did as well, related to advanced care planning. I also know that we're working on a PCORI grant on advanced care planning, serious illness conversations in across Canada and Oregon with primary care. And we've made some of the materials that are part of the research project available on a website. And I will make sure that I share it. I don't have access to it right this minute, but I'll make sure it gets shared with you when we send out our follow-up email, so that you can connect to that as well as as a resource. And it's one that's had input from the patient and family research advisors that we are working with in that particular project. So we're getting ready to kind of wrap this up a little bit. So I want to share a little bit of information, and then, but before I do, is there anyone who hasn't had the opportunity to break into the conversation either by chat or auditorily that want to share a thought or share something that I haven't called on you, but you want to share? So I'm going to make it some quiet.
This is Keisha Goodnow, University of Cincinnati.
Hi, Keisha. How are you?
I hope everyone's well. I just wanted to share that I think the biggest thing for us in managing our PFACs during this crisis is that it's not a one-size-fits-all, and it's not an across the board. So we really have been surveying advisors every opportunity we get, and I'm amazed at the diversity of responses that we're getting. So a lot of our advisors will say, I am bombarded with Zoom, WebEx, video platforms all day long. The last thing I want to do is have a video meeting with my PFAC. I miss you, but it's not what they prefer. And so we actually are using a lot of text, a lot of email, a lot of other asynchronous methods for them, because it is exhausting. I mean, we're all doing this all day long. So I just wanted to say that I think it's really important to keep that in mind. And then in addition, working with some of the populations, phone and data limits, and a lot of people have lifted those restrictions during COVID, but there are still advisors who are, who don't have the minutes to be able to do like a video call. So it's just really important to find out where your advisors are and then try to be more patient-centered and not, across the board, this is going to be our decision.
Great. That's a great comment, Keisha, and I appreciate you stepping in and sharing it. So we're going to wrap up. If we can, Natasha, go to the next slide and the next one beyond that, because we've already talked about our PFACs. So for those of you that are on the call and are not members of PFCC Connect, we continue these conversations in an asynchronous way on PFCC Connect, and it's a free online learning community, so we encourage you to join. I also, next slide, want to bring to people's attention that we have created a PFCC and COVID-19 section under PFCC best practices. Marie had a lot to do with getting this up and running, and so I want to just bring it to your attention so that you can, and we will continue to add things to it. So there's live conversations in PFCC Connect, but there are some materials that are available on our website. So feel free to check back with that every once in a while so that you can see what's going on. And we'll go to the next slide. The other thing that we will be sending out with your follow-up email is a FAQ sheet that we're just finalizing. We imagine that we'll put together a number of these, but based on some of the conversations we've had in the last few weeks, we wanted to put together kind of a document that kind of summarizes some of the best practices available out there. Now, we do have a COVID-19 community specific within PFCC Connect, and you can certainly chat questions there. You can chat them in the all-member community, but what we'll do is we'll make sure that the recording of today's conversation, the chat record, any relevant links from IPFCC end up getting embedded in PFCC Connect. And we really encourage you to add additional links, examples, tools. begin or respond to discussion questions. There have been some really robust discussions happening in PFCC Connect. And if you are having trouble with the technology, Natasha Reed is just this wonderful resource at IPFCC for you. So we encourage you to be sure and reach out to her and let her know that you may need some technological help being able to do that. If we can go to the last slide, and Marie is going to put right now in the chat as we're finishing up the link to the SurveyMonkey that is our evaluation tool that we use and pay close attention to. And we know you're really busy, so we're putting the link in the chat so that you can click on it immediately and it takes 3 minutes to fill out the survey about how today's conversation went, what additional information that you would like to see us chatting about in the near future, and then we can take that information and we can act on it. Your input to us is extremely important because we want to make sure that we're filling the need for support and ideas and encouragement during this time, and always. We value our relationship with you and the work that you're doing out in the field, both as a patient and family advisor, as leaders in healthcare in the community settings that you work in. You're really making a difference, and we applaud you, and we want to support you in whatever way we can. So there's an open comment section at the end of that survey where you can tell us how we can help. So we're going to end this call. We want to thank you very much for your contributions. This was a very rich discussion, both on the chat and in person. And again, it's been great to see your faces, and you take care of yourselves. Stay safe out there.